that is maternal adaptation of pregnancy, then anemia in pregnancy, drugs in pregnancy, heart diseases, plus we try to cover diabetes, hypertension, and Rh negative pregnancy. So let's go to page number 353. Okay, 353. Okay. Coming to maternal adaptation in pregnancy, so first we have the cutaneous changes, then we'll have changes in reproductive organs, and after that we go to the endocrine changes, then the general changes. Okay, hematological changes, renal changes. Okay, we'll come to this one by one. So first one is the cutaneous changes. So what happens? Cutaneous means skin. Okay, so in pregnancy we know that there is estrogen increases in pregnancy, so it also stimulates the MSH, that is melanocyte stimulating hormone. So because of this melanocyte stimulating, there will be increased release of melanin. So melanin causes pigmentation, right? So pigmentation will be seen especially in the linea nigra, that is this is called linea nigra, which is a line which starts from the xiphisternum to the pubic symphysis in the midline. It's a darkly pigmented line. Coming to the next skin changes is there is stretch marks. Okay, and the stretch marks of pregnancy is called as stria gravidarum, which is a stretch mark of current pregnancy, and silvery gray, which are called as stria albicans. Albica means white or gray, silvery white or gray. So albicans, these are the stretch marks of the previous pregnancy. So stretch mark of the current pregnancy is called as stria gravidarum, whereas that is of the current pregnancy, whereas stria albicans is of the previous pregnancy. Okay, coming to something called as melasma or cloasma, that is pregnancy mask or cloasma gravidarum is it's a pigmentation seen on the face in case of pregnancy. And then we have the palmar erythema and spider nevi. So both of this condition is because of increase in estrogen. We see this as a sign of liver cell failure also, where there is increased estrogen, right? So here also there will be increased estrogen. So this causes peripheral vasodilatation. Vasodilatation, which causes increased blood circulation to the palms, especially in the outer aspect, but here it will be like in the center it will be pale. So this is called as palmar erythema. Whereas spider nevi is nothing but dilated capillaries, especially below the skin. Okay, below the skin it occurs. So this will have a central arteriole with the dilated spidery leg appearance. So it will be like this. So here, so if you press this in the center, so the you will see the blanching, and if you leave it, then you will see the blood coming from the center to the periphery. Okay, coming to the changes in the reproductive organ. So first reproductive organ which we'll be studying is uterus. So what happens in uterus? First, obviously the change of the uterus weight, especially from it increases to about 1.1 kg, okay, or 1100 gram, and this is due to both hypertrophy and hypoplasia. So generally a question comes in pathology like pregnant uterus is an example for what? So pregnant uterus has both hyperplasia and hypertrophy. So hypertrophy. So hypertrophy is the main thing which happens. Actually hypoplasia is only limited to the first trimester. Then hormones responsible for this changes in the weight is especially progesterone. So whatever skin changes we studied was due to estrogen, whereas whatever changes in the weight it occurs is due to progesterone. Okay, so there's also increase in blood flow and increase in uteroplacental blood flow, that is it increases to 500 to 750 ml per minute, and also it is dextro rotated, so uterus gets dextro rotated. What is the reason for this? Is presence of sigmoid colon, and the sigmoid colon rise to the right side, right? So because of the sigmoid colon which is filled with the feces, the uterus gets pushed to the side, that is right side, is called as dextro rotation. Okay, so coming to the breast is there is a growth as a growth of the all the three components of the breast. The first one is ductal component, then there is alveolar component or the lobular component, as well as the fat. The fat deposition is due to insulin, whereas the alveolar is due to estrogen plus progesterone, whereas ductal is mainly due to estrogen, increased estrogen. So this is due to insulin. Okay, so fat is due to insulin, alveolar and ductal. Alveolar is both estrogen, progesterone. Ductal is due to increased estrogen. So that's about the growth of the three components. Whereas colostrum is what? Colostrum is a yellowish discharge, which that is initially the milk. The initial milk is rich in immunoglobulins. These immunoglobulins, that is called as colostrum. The earliest milk is called as colostrum, which is yellow, and that is expressed by 12 weeks of pregnancy. Also you can see Montgomery tubercles around the areola. There will be increased this elevation of the tubercles called as Montgomery tubercle. Coming to the cervix, okay, we see one sign called as Chadwick sign. So what is Chadwick? Chadwick is bluish discoloration of the cervix and the vagina. Okay, Chadwick and Jacquemus sign. So the mouth of the cervix gets closed by the mucus plug. So this helps in preventing ascent of infection and release of this called as show. So now coming to this, what happens in pregnancy is, for example, if this is the uterus and this is the cervix, so and this is the vagina. Okay, so here you get mouth of the cervix gets obliterated by something called as a mucus plug. Okay, mucus plug. So what happens if this is the fetus inside, so it will prevent the ascent of the infection, as well as it prevents the expulsion of the fetus. So both, it prevents this also, it prevents this also. So upward and downward, this prevents both. Okay, now during the labor, what happens is this mucus plug along with the blood plus mucus plug, which gets expelled because of contraction, that is true labor. So this is called as show. What is show? Show is a blood plus mucus plug which is released during the true labor. Then coming to the there's also along with hypertrophy or hyperplasia of the uterus, there are also cervical hyperplasia. The length of the cervix becomes 4 to 5 centimeter. What is ectropion? Ectropion or the ectropion or eversion. So we know that the cervix is divided into two parts. For example, if this is cervix, okay, this is the endocervix and this is the ectocervix. Okay, so what happens monthly? So this endocervix and this cervix it comes from, that is endocervix gets converted into ectocervix. So like the cells migrate and get metaplasia. So here it is the squamous, here it's columnar, right? So here we have the columnar epithelium, whereas here it's the squamous epithelium. So every time it comes, so there is migration of the cells and it gets converted to metaplasia. Metaplastic changes takes place once the endocervical epithelium comes to the ectocervix. So columnar epithelium of the endocervix grows over the squamous epithelium. So here what happens is excess growth of the columnar epithelium over the squamous epithelium. So it's called as ectropion. Excess growth occurs. So this can present as a postcoital bleeding, and it's not a pre-malignant condition, so there is no need of biopsy. Okay, so this they have per speculum examination, you can see the cervix as like this. That is, this is the internal os, and we have the ectocervix. This is the endocervix and this is the ectocervix. Okay, exo or ecto. Okay, so what happens in the vagina? So this was the cervical changes. So what was the cervical changes? First one is the Chadwick or the Jacquemus signs. Then the mouth of the cervix gets filled with the mucus plug, which if released during the tubal labor pain is called as a show. And there is hypertrophy, hyperplasia of the cervix, which is there is increasing the length of the cervix to 4 to 5 centimeters. Then there's something called as ectropion or eversion of the cervix. Ectropion is the extra growth of the columnar epithelium of the endocervix grows over the squamous epithelium of the exocervix, that can present as a postcoital bleeding and not a pre-malignant condition, so no biopsy is needed. Coming to the vagina has a bacilli called as dodeline bacilli or lactobacilli. So that is important for conversion of the glycogen to the lactogen, and this is responsible for lactic acid. This is lactogen or nothing but lactic acid. Okay, and this is, since its acid is helps in keeping the pH of the vagina as acidic, that is 3.5, less than 7. Okay, 3.5. So what happens in this is, there's so because of this acidic pH, there is no pathogenic bacteria. Okay, no pathogenic bacteria is there, and most common vaginitis in Candida. So one peculiar thing about Candida is Candida can grow in acidic climate, also acidic pH also. So only thing which can happen is candidiasis, because acidic pH prevents all the other microorganisms except Candida, which can survive in acidic pH also. Also there is this bluish discoloration. So I told that discoloration of both cervix and the vagina. So bluish discoloration of both cervix and the vagina is called as the Jacquemer or the Chadwick sign. Okay, so that is about the changes in the reproductive organs. Now coming to the endocrine changes. So endocrine changes can be, pregnancy is progesterone dependent, so it's a mainly progesterone dependent. So what happens is, because of the progesterone, the suspension of the ovulation, estrogen progesterone plus from the placenta, it causes a negative feedback, and hence it decreases the LH and FSH, and hence ovulation is suspended in pregnancy. So if there is, okay, so we know that the GnRH, which stimulates the gonadotropins like LH and FSH, and LH and FSH acts on the ovaries to produce estrogen plus progesterone. Now what happens is, this so much increase because of the excessive secretion from the placenta also, that it goes and inhibits the formation of LH and FSH. Okay, LH and FSH is not there. So because of this, LH and FSH is not there, and because of no LH and FSH, the ovulation gets suspended. Because this LH is responsible for FSH is responsible for follicle, and this LH is responsible for luteinization, right? Formation of corpus luteum. Okay, coming to the next one, that is amenorrhea. So since we know that in what happens in progesterone, if it increases, it helps in the endometrialization, like it helps in the formation of the, it supports the decidua. What is decidua? Decidua is nothing but the endometrium of the pregnancy is called as decidua. Endometrium of pregnancy is called as decidua. So it prevents the decidua from shedding. So if decidua sheds, that's called like menstruation, right? But it prevents this decidua from shedding, and hence it causes amenorrhea of the pregnancy. Coming to the estrogen, what happens is, there is increase in estrogen dependent changes in the pregnancy, dependent changes. Because of this, there can be, like first we studied about the cutaneous changes, right? Already we studied, and there is also increase in TBG, that's thyroid binding globulin, and also there is cholestasis. So this estrogen, what it causes, it decreases the motility of the bile. Because of that, there is increased cholestasis, and also there will be fluid retention. Fluid retention will be there, and also there will be onset of labor after certain weeks. Okay. So coming to the prolactin is the one which is secreted by the pituitary gland and the decidua. Okay, levels are during the pregnancy, the trimester it will be more compared to during lactation. So it's mainly yeah. Okay, so also it inhibits the formation of the action of the this one, right? So increased estrogen, what will do, it will prevent the action of the prolactin. Okay, so prolactin is secreted by the lactotroph cells of the anterior pituitary, right? So anterior pituitary plus the decidua, which is the endometrium of pregnancy, is responsible for formation of the prolactin hormone. Okay. Now what happens is, during pregnancy, especially during third trimester and during lactation, so lactation is one of the place where prolactin will be high, as well as third trimester it starts becoming high. So increased estrogen is the one which inhibits the prolactin action. So during the entire pregnancy, milk is not ejected, right? Milk is not produced, not ejected. Sorry, oxytocin is responsible for ejection of the milk, whereas prolactin is for production, right? So milk is not produced during pregnancy. After delivery, what happens is since the placenta gets delivered, there will be decreased estrogen, and decreased estrogen is the first stimulus for lactation. So there is decreased inhibitory effect on the prolactin, and there will be milk production. So this is how the thing occurs, right? Okay. So what did we study? We studied first about the skin changes, then we studied about the reproductive tract changes, then we have studied about the endocrine changes. So what are the things we studied under endocrine changes? Endocrine changes where we studied about the estrogen, the progesterone, the prolactin, right? Estrogen, progesterone, and prolactin. First we studied about the progesterone. Under progesterone, what did we study? We studied that main thing about progesterone is first ovulation gets suspended. There is no ovulation, there's no menstruation. Menstruation is also not there. So then about estrogen, what did we study? It is responsible for many of the things like fast cutaneous changes, increased thyroid binding globulin, there is increase in cholestasis, there is increase in this one fluid retention, as well as labor. During the onset of it causes the onset of labor. Okay, so now then we studied about the prolactin. Prolactin is the one which is released by the pituitary gland and decidua. There are levels during that pregnancy in third trimester is more than the during lactation, and increased estrogen can bind. It inhibits the prolactin. So during entire pregnancy there is no milk production, whereas as soon as the placenta is delivered, the estrogen supply gets cut off. Because of that, there is sudden decrease in the estrogen is the stimulus for the lactation. So this causes inhibitory effect on the prolactin, causing milk production. Okay, now coming to the generalized changes. General changes may BMR, that's basal metabolic rate, increases by 20%. Almost it increases by 20%. Hence it's called as anabolic state. Anabolic state, that is bodybuilding, right? Anabolic and catabolic. Catabolic means it's destruction, whereas anabolic means it is synthesis, or it is bodybuilding. Yeah, coming to physiological edema, causes a retention of the fluid, almost 6.5 liters of fluid. This is because of sodium and potassium retention, as well as concentration of sodium potassium is decreased due to dilutional effect, and also the fluid plasma osmolarity decreases due to fluid retention. The pressure of the uterus on the inferior vena cava and hypoproteinemia. So what are the causes for physiological edema? Is that first is there is retention of fluids, almost 6.5 liters gets retained, and then there is pressure on the inferior vena cava. Because of that, there's fluid extravasation as well as hypoproteinemia during the pregnancy can cause. When there is decreased albumin, what happens? Because of this decreased albumin, there will be decreased albumin is responsible for fluid retention, right? So hypoproteinemia means there's increase in the third space fluid. This causes edema. Okay, so coming to how to differentiate between the edema which is physiological or pathological. This is important, Viva. So for example, on rest, okay, so if the edema subsides, then it is obviously physiological. If it does not, then it's pathological. Pitting type of edema is a physiological edema. If it is non-pitting, then it is not physiological. So it can be due to mixed edema, it can be due to angioneurotic edema, or it can be due to filarial lymphatic obstruction. Okay, so that's the thing. Okay, about the sites, obviously physiological edema is the one which is on the dependent parts like feet, on the standing sacrum, on lying down, whereas pathological edema is above the knee, that is anasarca. Anasarca is generalized edema, right? That is all the fluid, the cavities get filled with anasarca is the all the cavities like peritoneal cavity, then pericardial, pleural, there's all accumulation of the fluid in these cavities. Okay, management of physiological obviously is not required. There's rest and reassurance, whereas for pathological edema, as in case of PIH, you have pathological edema, you need to required treatment, that is you have to give the specific treatment for whatever is the cause. Coming to the hematological changes, so hematological changes may we have the parameters which increase and parameters which decrease. Coming to parameters which increase, we have the plasma volume, blood volume, and RBC volume, hemoglobin, oxygen carrying capacity, erythropoietin, reticulocyte count, MCV, WBC count, all inflammatory proteins like CRP and ESR, and then clotting factors, especially these two are not it is excluding this. All the other clotting factors are increased. Hence it's called a hypercoagulable state. And plasma protein in grams, that is globulins increase. Obviously we studied about thyroglobulin. Now also sex binding hormone binding globulin also increases. Okay, so obviously we know that because pregnancy is a so there is hypervolemia. Okay, hypervolemia, right? There's increased fluid retention. Because of that, there's a plasma volume increases. Obviously plasma and blood volume both increase. Blood volume by 40 to 50%. RBC volume also increases. There's hemodilution dilution. That is, then hemoglobin mass also increases, oxygen carrying capacity increases, erythropoietin increases, reticulocyte count increases. So what is the cause for reticulocyte count? Is because of the increased erythropoiesis. MCV and WBC counts also increase, that is it becomes more than 15,000 in pregnancy, and more has to happen during labor, right? Because during labor there is the contact with the external environment, so it increases further, especially the neutrophils will be seen. Okay, so coming to the factors that parameters that decreases, first is blood viscosity. There is hemodilution, right? Then hematocrit, due to more increase in plasma volume than RBCs. Plasma volume increase much more than the RBC increase. Because of that, there is decrease in hematocrit. Hemoglobin concentration does not fall below 11 gram per deciliter. RBC lifespan decreases. Platelet platelet count doesn't go below the normal range. It's called benign gestational thrombocytopenia. Clotting factor 11 and 13 either they decrease or remain unchanged because they are estrogen independent, right? Okay. And then there's a decrease in fibrinolytic activity. Because of increase in clotting factors, there is more thromboplast coagulate. So these two are opposite, right? So if there is increased coagulation, there is decreased fibrolysis. Okay, then protein C, protein S, these levels also decrease. The plasma proteins also decrease. Albumin decreases, that is hypoalbuminemia, and that further increases the edema, right? Okay, AG ratio becomes 1:1. So normally it is more than 1:1, right? But what happens is that since there is globulin synthesis increases, that is because synthesis it becomes more due to increased estrogen, but albumin is decreased. Okay, albumin decreases, why? Because of hemodilution, right? Hemodilution, plus there is a hepatic protein synthesis is altered. This causes increased globulins compared to albumin, right? So it becomes 1:1. Okay, 1:1. Okay, coming to hemodilution, compensatory mechanisms occur, that is increased cardiac output, increase in 2-3 BPG, right shift of the hemoglobin oxygen dissociation curve, increase SpO2 and decrease blood viscosity. Whereas parameters that remain unchanged are BT, CT, APTT, MCHC and pH. Okay, so what is A plus syndrome? In A plus syndrome, you have antiphospholipid antibody syndrome, right? So there is increase in APTT, isolated increase. Okay, only APTT increases. All the other things remain normal out of this. All the other things remain except APTT increases. Plus there is history of thrombosis. Okay, coming to the renal changes, we have the size of the kidney which increases by 1 centimeter. There can be bilateral hydroureter. Why hydroureter? Because there is increase in progesterone, right? This progesterone is a smooth muscle relaxant, and hence there is decreased peristalsis and there is urinary stasis. And as the urine stasis happens, the ureter gets expanded. So this is called hydroureter. And also in anywhere there is stasis, the bacteria easily comes and multiplies, right? So that causes increase in UTI. Then right to right, this is more than the left, because what? Because of dextrorotation of the this one, there is increased pressure on the right side. So right side hydroureter is most common. Coming to renal blood flow also increases, and GFR increases by 50%. Increase in filtering capacity of serum urea, uric acid and creatinine. Increase in urinary frequency, especially in the first trimester and the third trimester, takes place. What happens in first trimester? What happens in third trimester? First trimester, what happens is that there is irritation of bladder because of the growing uterus. This growing uterus, the growing uterus will go and like irritate the bladder, right? Because of that, there will be increased micturition, and this is relieved because in second trimester what happens is the uterus becomes a abdominal organ. So uterus becomes abdominal organ in the second trimester. So because of that, there is no irritation of the bladder as such. In third trimester, again the descent of the fetal head happens. Because of that, this fetal head into the pelvis also can cause irritation of the bladder. Blood pressure increases due to, and because of increase in blood pressure, there is increase in SUI, stress urinary incontinence. What happens in urine microscopy and routine, which is for the done at first antenatal visit? First, what happens? Glycosuria happens. That's glycosuria. Yeah. So it's to rule out diabetes. So if it is negative, then it is physiological glycosuria, that is due to decrease in renal threshold to the glucose. Coming to proteinuria, is not physiological, but it can be seen in pathological condition like PIH. Asymptomatic bacteriuria can be there. There is increase in bacteriuria. What is asymptomatic bacteriuria? There is no bacteria, but there is presence of the pus cells. Yeah. So in sorry. Asymptomatic, there is no symptoms, but there is presence of the bacteria. So that is more than 10 to the power 5 bacteria per ml of midstream urine. That is clean cat midstream urine. There is no UTI symptoms. Okay. Most common organism is E. coli. Urine routine microscopy should be repeated every trimester to monitor the asymptomatic bacteriuria. Okay. Complications of the asymptomatic bacteriuria is what? It can cause preterm labor, cause acute pyelonephritis in 25% of the cases. Risk factors for asymptomatic bacteriuria is diabetes as well as sickle cell anemia. What's the management? Is drug of choice is nitrofurantoin. Recurrence rate is what? 30%. Okay. Coming to the GI changes. Okay. GI में what happens? Motility increases because progesterone causes smooth muscle relaxation. There's increased GERD because of relaxation of the sphincter. Increased constipation because there's decreased motility, right? And gallbladder contractility is also decreased. Because of that, there'll be gallstone because of the stasis, cholestasis, right? So this gastric increases during the gastric emptying time, increases but normal during pregnancy but increases during labor. Hence clear fluid is recommended. Solid fluid is not given during labor because there is increase in gastric emptying. Okay. Hepatic enzymes are ALP, that is due to release from the placenta, that's heat stable ALP, and also the liver releases it. SGOT, SGPT is remaining normal. If it is elevated, it's suggested of elevated liver enzymes, right? So it is a component of HELLP syndrome, that is hemolysis, elevated liver enzyme and low platelet. Okay, coming to respiratory changes. Respiratory mean we have anatomical changes, increase in, decrease in, constant. Okay, so first is anatomical changes, which is pneumonicus 246, 2, that is transverse diameter increases by 2, diaphragm pushed by 4 centimeters upwards, and then we have chest compression has increased by 6 centimeters, and there is increase in subcostal angle. Coming to increase in inspiratory capacity, there is increase in tidal volume, minute ventilation. Why the minute ventilation increases? Because carbon dioxide washout causes respiratory alkalosis. There is also SpO2 and increase SpO2 increases, whereas SpCO2 decreases because of this carbon dioxide washout, and there is compensated increase in HCO3 minus to maintain the pH. PCO2 is responsible for maintaining the pH, right? So if this is washed out, then the counterpart of this is HCO3 in the kidneys, which increases, right? Coming to the constant, inspiratory reserved volume and respiratory rate and vital capacity remains constant, whereas decreases total lung capacity decreases, residual volume decreases, and expiratory reserve volume decreases. Inspiratory reserve volume is unchanged, whereas expiratory reserve volume decreases. Okay. Vital capacity, total lung capacity, right? Total volume. Other changes are what? So we have other changes like oxygen related parameters like increased oxygen carrying capacity, binding capacity, demand, and SpO2. Decreased is arteriovenous oxygen gradient. Coming to the iron metabolism, all the parameters are decreased except serum transferrin increases, TIBC increases. Coming to calcium metabolism, there's fetal requirement is 30 milligram for skeletal formation. Calcium it is 30 milligrams. RDA becomes 1000 milligrams or 1 gram per day starting in second trimester. Vitamin D is 400 international unit per day. There is increased GI absorption of calcium. Active form of vitamin D also increases. Bound form calcium and total calcium decreases. Coming to pituitary gland, increase in size by 125%, that is mainly anterior pituitary because of increased blood flow, and decreased blood flow due to BPH. If decreased blood flow, then it causes anterior pituitary necrosis, that's called as Sheehan syndrome. Spleen size increases by 50%. So in pituitary gland, important to remember is in PPH what happens is there is decreased blood flow to the anterior pituitary, which causes the necrosis of the pituitary. This is called as Sheehan syndrome. Yeah, that's all for this chapter.